Good evening, ladies and gentlemen. Welcome to our webinar on GIT this evening. Just give us a few minutes. Daktari was handling an emergency. He's just finished, so he give us about 10 minutes so that he's able to set up and join us. Thank you.
Hello, Caroline.
Hi, Daktari, welcome.
Thank you.
And Pole for the emergency.
That's okay.
Okay, so guys, we are on. We already have some people in the team waiting for your presentation.
Okay.
Welcome this evening to our webinar. Today we are going to talk about GIT issues. The word itself is very hard for me to pronounce from where I'm coming from. So I know Daktari will pronounce it better when he starts making his presentation. We're going to have the first 30 minutes to where Daktari will take us through the various GIT issues. And after that, we're going to open up the panel for question and answer. Now, for question and answer, at the bottom of your screen, you will see a Q&A session. Just go there, type your question, and then Daktari will be able to answer. So Daktari, I think I want to give you a chance to introduce yourself, and then you can put up your presentation.
Yes, thank you very much, Caroline. My name is Dr. Eric Murunga. I'm a gastroenterologist practicing here in Nairobi at Gastro and Liver Center. So, yeah, thank you very much for the opportunity.
Karibu sana. You had a presentation?
Yes, I do have some slides. Unfortunately, I'm having a few technical issues because I'm trying to see how we went over it earlier, but okay, now I think that's better. Can you all see me?
Yes, we can all see you.
I want to share the screen. And okay. Can you see the slides and see the screen?
Yes, we can. Yes.
Okay. All right. Good. So, yeah, the presentation, I was asked to talk about gastrointestinal disorders. And as I introduced myself, I'm a gastroenterologist. I know that is a mouthful, but you can just say gastro.
Yes, that's why I was saying GIT, because I was trying to say gastro. I'm like, okay, that's enough.
Yeah, I just call it gastro for short. So anyway, so there's the digestive system, is a huge organ all the way from the mouth to the exit. And, there are many conditions or diseases that can affect this digestive system. So it's not only the tumbo, although that's what we talk about the most, but it's anything in that whole area. And so we really can't cover all the topics. And so we decided to just take a few which are common. So we'll have a short discussion. And then the rest of the time will just be driven by the questions and answers which come, which I believe, Caroline, you'll be asking on behalf of the audience. So I don't want to turn this into a classroom. I know probably everybody is tired. Nobody wants to go through, another classroom and, a huge lecture. So, just try to summarize a few things, and then we can have a nice discussion answering the questions and addressing issues that come about. So as far as introduction, this is, as I said, just a brief overview. Half the time will be me talking, and then we discuss. So there'll be many questions. Now, as I've said, the digestive tract or the GI system, you can see a picture of it there from the esophagus. We've highlighted the stomach. So we'll have two sessions. Today is session one. We're going to talk about gastritis and ulcers. These are things that affect so many people. Every time you get heartburn, everybody says, "Me nikona ulcers." So we'll tackle that in brief. Then Helicobacter pylori. This is a very topical issue now. There have been many newspaper articles. There are those who believe H. pylori causes a lot of problems. Some people think it's all a scam and it doesn't really exist. So we'll discuss that briefly. Then reflux or GERD. And then lastly, diarrhea and other GI infections. Next week, hopefully we'll discuss a bit of constipation, issues to do with the diet, different types of cancer that affect the GI tract, like the esophagus, stomach cancer, colon, pancreatic. These are very, very common. And of course, we will have an open mind. So if there's a topic that seems to stand out, we can make changes and discuss something else. Then liver disease, alcoholic liver disease, hepatitis B infection. So we'll just get started right away with talking about gastritis and ulcers. So you can see from the picture, the left side, that is a normal stomach. And then on the right, this is where now you have the ulcers. And then beyond that, you can see gastritis, which looks like vidonda, rather than a distinct ulcer like you can see in this other one. So gastritis refers to inflammation of the stomach lining. It's the part of the same process which, when it gets more severe, it forms deep wounds which are called ulcers. They may be in the stomach or the small intestine, what we call the duodenum. And most of them are actually caused by H. pylori. So it is a real thing. It causes a lot of ulcers. And medications like aspirin, which might be in, if you buy headaches, you may not know it has aspirin, but it does. Same as Maramoja and many other over-the-counter drugs, and ibuprofen, medications like those. So combining H. pylori and this type of pain medication, almost more than 90% of ulcers and gastritis are caused by this. Smoking and alcohol also contributes to this problem. Now, symptoms, there are a lot of people who have ulcers and feel perfectly normal. They might have burning pain in the stomach, which may be made better or worse on eating. Symptoms are usually similar for both gastritis and ulcers, so you may not be able to tell between the two what is going on here. So you can see some people in this picture get vomiting, upset stomach, loss of appetite, bloating. If it's severe, it can actually cause bloody vomiting, like you can see in this lower picture here. Or it can cause black stool, which is also another sign of bleeding. And this is life-threatening. This is where now people have to go into HDU, ICU to get very, very good care. Now, as far as treatment, remember we talked about these medications over the counter, things like aspirin. So taking these medications or just in general taking any medicines which are not prescribed or are not good for you can cause problems. So William Osler is one of the famous doctors from the past. He's described as the father of modern medicine. And he taught a lot of physicians and introduced the modern practice of medicine. And what he said, one of his best quotes is, one of the first duties of the physician is to educate the masses not to take medicine. So every time we're popping pills left and right, I have a headache, I have some pain, I go to the pharmacy, take medicine, it can actually threaten your life. So stop taking this type of medicine. Of course, again, if H. pylori is the cause of this ulcer, we need to treat that. The thing is that a lot of the treatments nowadays don't work. So you really need to be sure that you're getting the treatments that work. A lot of the kits that have been used, quote unquote, for a very long time, not all of them work. The resistance rate is very high. And so you hear people who have taken kits 5, 6, 7 times and they say, I'm just not going to get better. No, it's a question of getting the second line and the third line treatments for these medications. Then other than that, medications like omeprazole and these acid reducers can also be helpful. So again, with regards to treatment, some people might require endoscopy. The endoscopy, you can see this is a doctor. Can you see my pointer, Caroline? Move him. Hello?
Yes, I can see the pointer.
Okay, good. So this is a patient here. He's sedated, he's asleep. These are the screens. This long pipe, once the patient is asleep, it goes right through your mouth and into the stomach and gives us the pictures that we've seen earlier. And this is what we call endoscopy. So it may be necessary if there's a serious problem like bleeding, and also to rule out conditions like cancer, which the symptoms may be the same as gastritis. And a lot of people have been treated, by the time they discovered they have stomach cancer, they've been treated for ulcers and gastritis for a long time. So usually, I mean every single person with stomach pain should get an endoscopy. But there's some things that can be a pointer that, look, this one, don't just take drugs. Let's just take another look. If the symptoms are not getting better with the medication and you keep going in and out of clinics and hospitals, if there is weight loss, that's a very big sign that something serious could be wrong. So then an endoscopy is needed. People who are aged over 40, and again, if people who are bleeding, vomiting, have low blood count, the anemia, difficulty in swallowing, all these people should undergo endoscopy. Helicobacter pylori. This is the big topic now in town. Everybody's talking about it. You've seen pictures of the COVID. Now these are pictures of the H. pylori. So usually it's an infection. So this is simply a bacteria, usually acquired during childhood. It might persist for many years and later on, may cause symptoms later. Some people don't even have symptoms at all. In fact, if you go to the mall and test everybody in Kenya, probably 60% will have it. Same thing in Asia. In the US and America and Europe, probably 35%. And this is a serious matter because it is thought to contribute to as much as 50% of all gastric or stomach cancer. So this is not something to be ignored. It doesn't mean though that we test everybody. It doesn't mean you run and get tested. Only people who have symptoms. If you have a lot of the symptoms we talked about in the prior slide, like pain and things like that, then you get tested. If it's there, you get treated and you make sure that the treatment has worked. So it's easier said than done because the treatment and even the diagnosis is not easy. There's no test that is 100% accurate, and many times you do different tests to increase the accuracy. The stool test is a good test, but you can have a false negative if you've used antacids or antibiotics within the last 1 month. The blood test is also, it can give you false positive. In places like Europe and America, where their rate of H. pylori is low, they don't recommend using the blood test in those areas. But according to the international guidelines, which guide us on management of this condition, in areas which don't have a very high level of H. pylori in the population, it can be used, but it has to be used carefully and knowing what you're doing, because you can get a false positive. So if you got treated last week or last month, you don't do the blood test because that's going to remain positive for several months. Biopsy can also give you a false negative if there's antacid. So a negative biopsy doesn't mean that you don't have it. And this is usually done during an endoscopy, where a small piece of that tissue of the stomach is taken to the lab and tested. So treatment, we've talked about, sometimes the kits work or don't work. Sometimes you add other things like Pepto-Bismol or probiotics to increase the chances of success. These are chewable tablets that make the stool black, but they can actually help the treatment to be very, very effective. Usually the treatment is taken for 2 weeks, not very easy to tolerate. So it's not an easy treatment. You have to really be motivated. I always try to give my patients a pep talk that, look, you have to do this, take this medication this time, this and this can happen. And when you encourage people, a lot of people really try their best at it and they get success. And then you should not repeat the same kit or the same combination of medications. So if one had clarithromycin as one of the components, even if you do that 5-6 times, it's never going to work. Then the other condition that we'll touch on is called GERD or reflux. GERD stands for gastroesophageal reflux disease. It's where the acid moves up from the stomach up to the esophagus or the food pipe, causing heartburn, sore throat, symptoms like pain behind the chest and things like that. It happens when this valve here, this is a sphincter between the food pipe and the stomach. If it doesn't close when there's food in here, when it's supposed to be closed, then the food will go up and cause a lot of burning into the esophagus, and that causes the GERD or reflux symptoms. Hiatal hernia is also a condition that you may have heard of. It means that the stomach, like you see in this picture, it herniates. So this is the diaphragm. It's supposed to be, go back to this picture, this is a diaphragm. The whole stomach is supposed to be under the diaphragm. But if part of the stomach kind of pushes up through the diaphragm and goes above the diaphragm, then you don't get very good protection. The acid doesn't remain in the stomach. It just keeps flowing up and causes a lot of discomfort and reflux, the way you can see in these pictures. Then how do you make a diagnosis of this condition? Usually by the symptoms. You might have heartburn, and this might be worse at night once you lay down. Some people tell me I wake up every 4 a.m. or 3 o'clock. I'm just choking, the food is going up. But then when you raise the bed, when you sleep at an angle, you find that, it's better, it's more tolerable. So people find that, you get this heartburn, but you sit up and then you get better. It can also cause very unusual symptoms like cough or wheezing, and you might think it's an asthma, but that's what it is. Now, you might have chest pain, but now if you have chest pain, don't assume it's from GERD, because it's very important if you have chest pain, especially in older people or people with risk factors for heart attack, like diabetes, make sure it's not a heart attack, okay? So once you rule out a heart attack, then now you can start dealing with reflux and GERD. And endoscopy, again, is not always necessary, but in people who have features like weight loss or these symptoms are just not getting better, you want to do an endoscopy because that's really the only accurate way that you can rule out serious things like cancer. Treatment, it's okay to use over-the-counter antacids at first. If they're not working, then you go to omeprazole, pantoprazole. Such medications, they should be taken strictly 30 to 60 minutes before breakfast or supper. So if you use something like Nexium or omeprazole or things like that, make sure that you follow strictly this timeline. Otherwise, if you take it after food, it's not going to work. And initially, this can be taken as needed only, but if it's worse, then you can take them every day. But then definitely, it's good to discuss these options with your doctor so that we're not trying to self-medicate, because like we've seen before, taking medicines can be harmful if it's not the correct one for you. Now, as far as other than the medication, dietary changes and lifestyle changes can also help with reflux. For instance, if you're overweight, you can lose weight or elevate the head of the bed, such as putting a wedge under the mattress or putting blocks under the legs of your bed so that it's at an angle. Then don't lie down after eating for at least 3 hours. So if you normally sleep at 10 p.m., you should have completed your supper by 7 p.m. Then avoid coffee, tea, soda, spicy or oily food, alcohol, smoking, chocolate, or peppermint, because these are foods that can actually make the symptoms worse. Also, tight-fitting clothes. You see, all those nice, fashionable clothes can actually be making your reflux worse. And this is not only for women, because even men nowadays, some of these shirts that people wear and suits, they're so tight you can hardly breathe, or you have a belt there and the kitambi is just hanging over. If it's too tight, then be careful about that, because you want your reflux better. Now, lastly, we'll talk briefly about diarrhea and other GI infections. So diarrhea is simply just very loose, watery stools, which are more frequent, and it's a major killer in Africa, especially young children. Children with diarrhea should see a doctor very, very quickly, because that can be life-threatening. And the maps you're seeing on your right are talking about mortality rates. So the more purple areas, these are areas, this is in the year 2000, and then this is also 2000, this is 2015. So you can see there's less purple here in Africa. And Kenya, there's more blue, so that's a good thing. So here it means from the year 2000 to 2015, we've done better in as far as reducing the number of children who die from this. So this is something we take very, very seriously, especially in children. Now, it's important to avoid dehydration. That is the riskiest thing about diarrhea. So if somebody in your family is having diarrhea, ORS sachets, those little sachets that you mix with half a liter of water, very important, especially for children, but even for adults. They look like this, the sachets. And for children, if they're very young, maybe half a liter at least in a day, or a liter. But so your doctor really should be involved, because this can be serious. Now, even in adults, if you're having a lot of diarrhea, just drink ORS. If not, then things like drinking soup. Soup has salt, so plain water is not very good. But if you have soup, it has salt. That's good. Or juice, and then you eat salty things like crisps, or with juice. Then you get, because you need a little bit of sugar, a little bit of salt. So, but fluids, definitely a lot of it. And then if the stool contains blood, that makes it dysentery. That's more serious, requires urgent testing and treatment. And anytime you see blood in the stool, don't assume it's an infection. It could be cancer. So these are things that needs to be looked at very, very closely, just not to be an alarmist, but just to make sure that nothing serious is ignored. Okay. So there are other rare causes of diarrhea which exist. Food poisoning can cause vomiting and severe pain. Now, COVID-19, we can't have a talk without mentioning COVID, because that is what is really causing a lot of problems right now. COVID-19 infection can also present with diarrhea. So there's some people who don't have cough, they're not short of breath, they only have diarrhea, and it's COVID. So that's happening now. We are noticing more and more of that. Then people who are over the age of 40, with a change in bowel habits or blood in the stool, and even if they're younger, I mean, sometimes you get people with these symptoms, and it could actually be cancer. I mean, you've diagnosed people in their 20s who had blood in the stool, and it turned out that that's what it was, unfortunately. So that is exactly where we are. So thank you and stay safe. So that is the talk. And Carol, you can take over and we can go to the next step and discuss any questions which are coming up.
Okay. Thank you, Daktari. I like the way you are saying not to spook you in a very gentle way. I wish you saw our faces on this other side. We are totally spooked.
Paul, that was not the intention. I think, sometimes it's a reality. You have to discuss the reality.
Okay.
But it's not common. I'm not saying everybody who has that, but you have always to consider. When you have a patient, you have to think, what's the worst case scenario? Then you rule that out, especially things like blood and weight loss. Those are not symptoms that we take lightly. So yeah, so, it's important to remember at the back of our mind that it could be serious, but not in all cases. And there are those conditions which you've seen that can prompt you more to be more aggressive in checking.
Okay. Now, I think one of the issues that is very common in Nairobi, especially, H. pylori, because I can see a lot of questions are coming around that. So the patient was diagnosed, or the listener, sorry, let me not call them patient, my apologies. The listener was diagnosed with H. pylori and put on the HP kit. They were not asked to go back for another test to check if the H. pylori bacteria is gone. Was this in order?
Well, I would say, in general, it's good to check that it's gone. There are some times when the patient takes the medication and the treatment and they feel so much better and they may not even necessarily, it's not a must to do it, but it's in the ideal situation, it's better to do that. Normally, you shouldn't be tested too quickly. If you finish the kit today, you can't be tested tomorrow because it's going to be falsely negative whether it went or not. So many times it's good to come for testing probably at least a month after completion of the medication. So many times we tell the patients come after a month, or if they're sick, maybe we can see them in 2 weeks just to make sure they're getting better. If they're fine, then they come back a month later, and then you're able to do the test. So that, as far as testing, that is the ideal situation. I wouldn't say it's mandatory, but it always helps if it can be done.
Okay. Another question, we are seeing such an upsurge of reflux in babies from age 2 months to 6 months and more. Why is there such an increase? And since there are no drugs indicated for this, or no drugs tested specifically for GERD and infants, then what do we do with the babies?
Yeah, okay, that's a very good question. And I'd like to say, first of all, that I'm not a pediatrician. So, my advice on babies might be limited, but in general, reflux does exist in babies also. And sometimes it's colic. Sometimes the issue might be more of colic than reflux. So, it's always good to involve your doctor so that we are clear on the diagnosis. Is it reflux? Is it colic? Or is it something else? And if that's the case, then treatment can be indicated. In fact, there are some pediatricians or pediatric gastroenterologists can prescribe omeprazole. Sometimes they formulate, like in one of the hospitals, they formulate, and actually, because usually these medications come for adults, but they can make it for children, and it can actually help. So yes, there are drugs that can be given even for babies when they have reflux. It needs to be done by your pediatrician to make sure that it gets the correct dose and the correct diagnosis.
Okay, I think our listener's question was mostly pointing to why the surge in such cases. Probably, was this there before, a long time ago? Seems like it's now increasing.
Yeah, that's something that I would say probably, again, saying that I'm not a pediatrician, but these are, a lot of times people are becoming more and more aware of these conditions. So it may not be that they were not there, but maybe they were just dismissed as colic. Oh, this is colic, just pop your baby. But now, we're able to recognize it more and say, oh, this is reflux. Probably in the time or when our parents were, the older generation had young babies, probably maybe no one told them that it was reflux.
Yeah. Okay, another question. H. pylori medications kit. By the way, before I ask this question, listeners, kindly put your questions in the Q&A session, not this chat area, because if you put on the chat area, I may miss some of the questions. Put them on the Q&A session. Okay, to this question, H. pylori medications or the kit seem to be very expensive currently in Kenya. Do you have an advice on measures that somebody can take to avoid the H. pylori?
Well, so as far as the question about the cost, it is true. A lot of the kits are expensive. Like I said, it's also important to know the ingredients of the kit. So the doctor, when they're prescribing, would probably avoid certain types that are becoming less effective nowadays and go for the types of kits which are more effective. Now, sometimes, the kits, it's just the same medication that you can buy separately. When it's in a kit, it's more convenient to take. So it's not that it's necessarily a better drug. So sometimes, especially if cost is an issue, one can get the medications prescribed separately. So if it's the levofloxacin, if it's amoxil, esomeprazole, you can get them separately instead of it coming in a kit. And it can actually be cheaper when that is done. So sometimes we end up doing that. So it's a question of cost versus convenience. As far as avoiding it, it's really hard to avoid because, like you remember in the slides, I said most times people get this when they're children. So it's in childhood. Yeah. So it's a childhood infection that just lies there and you may not know. So it's unlikely or it's not very common to get this infection as a grown-up. Sometimes people get treated, they feel better, then they go and the test, it's negative. Then they go after 6 months, they test and it's positive. So you think you're getting new infections every time. No, it's probably the same one. But then when the testing was being done, that was a time when it was false negative. So, so the issue is the correct diagnosis, the correct treatment. Reinfections are not very common.
Okay. And to a related question, is it associated with the socioeconomic status?
Yes, actually, there is such an association, not 100% of the time, but there is an association. So, and partly that's the reason you find, in these other Western countries where, probably the standard of living over the years has increased, their numbers have gone down. Probably if you tested them 20 years ago, it would be higher than now. But even there, they've noticed that. And again, it's a socioeconomic status, probably one generation ago. You know what I mean? So, so right now, the socioeconomic status is good, but when you're a kid, the way it is, we're all playing with other children, saliva, who knows, so it can happen.
Okay. Someone else is asking, can you talk a bit about fermented food like kombucha? Is it good for us and is it preventative?
Well, no, it actually would not prevent this because, like we said, it's an infection. It's an infection. Now, as far as this, a lot of yogurts and probiotics do exist. Probiotic yogurts, things like a lot of this, even maziwa mala, and some of these they have a lot of bacteria, and these bacteria are actually helpful and useful in terms of your gut health, because a lot of times when everything is so clean and sterile and you don't get this good bacteria, then that interferes with the function of the gut. So I would say, to me, the more important thing is not so much the fermentation, but the probiotic content or the amount of good bacteria that is in some of these products, like this kefir yogurt. That's known to have good amount. And mala, I'm sure probably if studies are done and it's tested, is really a very good source of good bacteria.
Okay. What advice would you give to someone who every time they eat, they get a lot of gas in their stomach?
Well, the issue is what is causing that gas. And like we said, sometimes it's just something as minor as the gut flora or the good bacteria in the intestines. So in that case, people like that may notice if they take some of that good yogurt and things like that, they get better. But sometimes it could be a point of even gastritis. Sometimes gastritis may present as just a lot of gas, or maybe constipation. Probably the food is not flowing very well. And in that case, this is somebody who might need to be checked to see what's causing the gas. Even H. pylori, by the way, if somebody has a lot of H. pylori with gastritis, they might get a lot of gas and treat it and they get better. But then again, we have to look at all the other factors we've talked about.
Okay. If part of the stomach is above the diaphragm, can it be pushed down, and how?
Yeah,
Okay,
well, that's a good question, because we talked about the hiatal hernia, where part of the stomach goes above the diaphragm, and this can make the reflux worse. Now, there are a lot of people who have this hiatal hernia, but they don't know. So not everybody who has that has symptoms. Some people, you just found you're just checking for something, and instead you notice, oh, here was a hiatal hernia. So it doesn't mean that it's a problem that must be fixed. And even if it's causing problems, even if it's causing the reflux, it doesn't mean you rush straight away and try to fix that, because if you can sort the reflux through medications and things like that, it's better, because then you avoid surgery. Now, the treatment of this hiatal hernia is a surgical procedure, and that is not done for everybody. It's not, doesn't work 100% of the time. I mean, there's nothing that's 100% successful. So you want to make sure that you really need it. So, and the surgery is where they do like a wrap, the part that is dilated, that is kind of, a bit, bigger than the rest, instead of having the smooth thing there, that is tied around and it's wrapped around, and that can actually help to increase the capacity of the valve to hold down the acid. So yes, it can be corrected, but it's not for everybody. It doesn't mean that's kind of a last resort when the medications are not working, or if there's another good reason to do it. So we don't rush to it, but there are a lot of patients who actually might need it, and then we refer them to a surgeon, and that can be taken care of.
Okay. Does taking Eno have bad effect?
Well, Eno can work as an antacid. You don't want to use it, too many times. Once in a while, it's okay, but there are better things out there. We don't recommend using it all the time. It can affect the pH of the stomach. So that, again, should be done cautiously.
Okay. What are some of the foods to avoid, and what should one consume more to avoid constant recurrence of H. pylori?
So H. pylori, like I said, usually it's not necessarily recurrence. It's probably partial treatment. So it feels like a recurrence because you get tested, you're negative, and then later on you're positive. But it's, in most cases, it's just that the treatment was partial. And so the key here is to get the correct combination of treatment. If you got one kit today with the first line drugs, clarithromycin and things like that, it's not working, then go to the next. In fact, many times we don't even use these clarithromycin-based kits nowadays because the resistance rate is too high. Nowadays, we go straight for the ones with levofloxacin in many, many cases, according to the resistant patterns in our country. And so the diet is not a very big factor in H. pylori resistance. The more important factor is what kind of antibiotics were picked, how well did you take them? Did you take them for the whole 2 weeks, or did you miss some doses? Or, some people, sometimes the side effects, I agree, they're not the easiest, and sometimes people don't finish, and then, it keeps coming back.
Okay. Someone else says they have had GERD for more than 3 years and have had 3 endoscopy procedures, and the endoscopy procedures have been normal. So I think what they're asking is what the problem could be.
Well, for GERD, a lot of times the endoscopy may not show anything. It'll only show symptoms, it'll only show features of GERD or GERD when it's more advanced, where it's forming ulcers in the esophagus and those types of things. But for the most part, if there's no gastritis that's associated with it, the endoscopy might actually look normal. But that doesn't mean the reflux is not there. It's just a subset of GERD, of GERD, that we call NERD. That's non-erosive reflux disease. The acronym is GERD. So we call it NERD. So instead of GERD, we say NERD. So that
G silent.
no, yeah, no, this is NAD now. It's just
Oh,
any
not GERD. Okay,
non-erosive
okay.
reflux disease. Yeah,
Yeah.
it's like a
Okay.
NAD. So
Or
it's a very
computer
funny
nerd.
acronym, but that's
Yeah.
what. So that's exactly what this patient has, because if
Mm.
you do the endoscopy and there's no erosion, but there are reflux symptoms, and all this is reflux you're dealing with, that is something that is very common. And the question is now, how do you manage that reflux? So that is the question. Then, the right medications have to be used. Sometimes you try this one, it fails, you do this, or increase the dose. So this is, GERD is one of those conditions that is not, it's not like malaria where you can take the dawa ishe tu mara moja. Or like this is an ongoing, I equate it more to hypertension. If you have high blood pressure.
So it's chronic.
Yeah, in many cases, it's something that might be there. Not in all cases, but in many cases, it's something that may be there for a long time. And so it means that you must take these treatments. You do all those, remember the slide about, raising the head of the bed and the non-medical thing. So you do all those things, and then you tailor the medication with your doctor. But then if you stop, it might come back. It doesn't mean that it's recurring. It just means that you have, it's like blood pressure. If you stop the medicine, the pressure will go up again. So that's what's going on.
Just on the same discussion, what actually is the cause of GERD? Because we have had GERD even diagnosed on babies. So what's the trigger?
Well, like I said, you remember that valve that we talked about? Huh?
Yes.
Now, that valve, if it is, I'm trying to go back to it. Now, so you can see, you can see the valve here. It's supposed to know when to close, when to open. So when you're swallowing food, you should go down this food pipe and then open, and the food goes in there. But so it can't stay closed when you're swallowing food. And then when the food is full in your stomach, it's supposed to stay closed. Okay, at that time, it shouldn't be opening. So in a lot of times, there's a lack of coordination. Okay, so it's not that the valve is totally useless or it's not working. It's just opening and closing at the wrong time. So when that coordination is lost, then you find it opens when there's food and a lot of acid in the stomach, and that goes up, and that's part of it. It's not known why now you lose that coordination very well. So it might be an issue. Maybe the nerves there are not functioning very well, but there's no clear indication of what causes it and what doesn't. What we know is that in white people, they tend to get more severe GERD than we do here. And in fact, in those people, it's very common to see erosions here where it looks like ulcers, like wounds in this area here of the lower esophagus. And that's what now we call erosive reflux disease. That's the opposite of NAD. And in that case, it can get to the point where it can even cause cancer of the esophagus in that area as a result of reflux. Now, this particular type of erosive gastritis is very common in the Western world. If you do a lot of endoscopies in white people, you might see it more. Here in Kenya, we don't see it as much, but that is exactly what happens. So, which suggests that there must be some genetic component why they get it worse than we do in that case. So there is probably some genetic component. It's not been proven. There's no gene that has been identified that causes that, but it is thought to play a role in addition to just the incoordination that you're talking about in this zone.
Okay. Now, is it advisable to do an endoscopy after having been treated for H. pylori multiple times, but symptoms still occur?
Yeah, I think it might be a wise idea because if, and remember when we talked about when do you do endoscopy, what are the indications or the proper reasons to do endoscopy? Persistence of symptoms is one of them. So if every single time, you get treated and, this is just not going away, then let's be sure there's nothing else. There could be something else. Or are we sure of what we're dealing with? Are we sure there's that H. pylori? So you need to look inside. So it doesn't mean that the first time you run for that, but there are times when things are just not improving the way they should, that it might be. And especially in those settings, we've talked about somebody who might even be vomiting or over 40 years of age or losing weight. those kind of things should really prompt you to, you don't just keep popping these medications, but it needs a thorough check.
Okay. I want to combine two questions. One has been on antibiotics for bacterial infection and GERD. They've done endoscopy and they are on medication for IBS, but they're still getting loose stool and mucus, like stool once in a while. So they're looking for the cause. And another one, a similar situation, they've had a prolonged acidity over the years with all medications given, ranging from kits to Nexium to omeprazole, but no change. And currently they're 37 weeks pregnant and it's getting worse. So both of them, one has GERD, bacterial infection, they've treated it for a long time, but it's not going away. They're even on treatment on IBS, but they're still getting loose stool. And another one who is pregnant now has also been on treatment for a long time with Nexium, omeprazole, and the kits, and it's getting worse. So what's the issue? Or what advice could you advise them?
Well, with pregnancy should always be, you have to be more careful with pregnancy to make sure that the medications that you're taking are not harmful to the child. Now, pregnancy causes reflux symptoms to get worse. So that's one of the things it does because, the tummy is full. There's a lot of pressure on the stomach from the uterus that is now so big. And then also the pregnancy hormones make the sphincters more loose and more likely to cause the reflux. And so when it comes to pregnancy, I think it's always good to discuss with the doctor, either the obstetrician. Sometimes they will give you treatment for those things because they deal with this all the time. Or sometimes if things are really not getting better, they might refer you to a gastroenterologist or a physician to try and see what else needs to be done. But with pregnancy, the key is to be sure that one is mindful that there's somebody else here who might also be exposed to these medications. As far as IBS and reflux, those are two different conditions. So, it might be that this person has both reflux and they're getting treatment for that and IBS. Now with IBS, one also needs to be sure that it's really IBS because, irritable bowel syndrome, or IBS for those who are not familiar with that term, it's a condition that can cause abdominal pain. The typical symptom is pain in most cases in the tummy. And in addition to the pain, one might have either constipation or diarrhea very often on most days of the week. And this is something that's usually for a long time. It's not a thing where you can have symptoms starting last week and then you say you have IBS. No, it's something for several months, at least 3 to 6 months. Now, the pain itself usually would be changed or affected by passing stool. So when you go to the bathroom, when you have a bowel movement, most people that relieves the pain, but in some people the pain can get worse. So those are the key features of the pain of IBS. And other things you'll find, some people get a lot of bloating with IBS. They might, and then the pain doesn't wake you up at night. So you find somebody with IBS, they'll sleep the whole night, but if it's another condition like an infection, you might wake up at night and your tummy is hurting. So if that's happening, then it may not be IBS. So I tend to be careful with that diagnosis of IBS and to make sure you've ruled out other things. Make sure there's no infection going on and make sure you really can attribute it to this so that if you rule out other things. So what I'm trying to say is, in this case, you need one, or this person needs to know that, are we dealing with IBS for sure, or is there something else that looks like IBS? Is it a mimic? So that's the first step. And then once that is clarified, then one can, if we're really sure that it's IBS, again, the treatment, it's a not lifelong, but I would say it takes a long term. It's similar to what I said with blood pressure and GERD. It's not a quick thing that you can get treated immediately and it gets better. There's a lot that, there's an IBS diet, okay? So with IBS, that diet is very specific. Sometimes one has to go to a dietitian. Then with the medications, one has to see which medications are we dealing with that are going to help. So I would say I would really urge them to be sure that that's what they're dealing with, and then know that the treatment for that and reflux, these are two different conditions which really may not be related.
Okay. Does pili kill the H. pylori?
No. I know it's hot, it feels like it's killing things, but no.
Okay.
Yeah.
Recently, I've developed gluten intolerance issues. Are the two related?
Now that's two between gluten intolerance and what?
I think and GERD or H. pylori.
H. pylori. Well, you know, a lot of times people who have H. pylori or have gastritis and even IBS, many times they will feel that the symptoms are worse when they eat bread or chapati or other gluten-containing things. So it may not be a real gluten intolerance. It might just be they have another underlying condition like IBS or such things that makes it, that gets worse when you take gluten. Because a lot of people will say, you know, when I stopped chapatis, I felt better. So there's gluten there. But then also when they stopped beans, they felt better and there's no gluten there. Or milk. So many times you'll find these people have several different things. But if it's a real gluten intolerance or, you know, what we call celiac disease. Now, celiac disease is now the real gluten intolerance, where gluten can make these people very sick. It makes them anemic, diarrhea. They can end up in hospital, ulcers in the small intestine. It's not a very common disease, especially in our population. Among Black people, it's not very common here. But of course, you know, our population also include other people from other origins like Europe and all that. And yes, it's a little more common there. But yet, even in those places, of late, there's a trend that is there of gluten sensitivity or gluten-free diets, which a lot of people feel that these gluten-free diets make them healthier or avoid this and that. In many times, it's more of a placebo effect with those things. These diets are expensive, and to really have a truly 100% gluten-free diet is not easy. It can consume your life to even, because, you know, like people with celiac disease, which I've talked about, even just like 2 milligrams of gluten or a tiny piece of bread can send them to hospital. Wow, so to be truly gluten-free is very involving. New Zealand is a country known for that gluten-free fad. Every other shop in New Zealand is has gluten-free this, gluten-free that. And, you know, what I would say in most cases is not necessary. It could be something else. Maybe it's just, I mean, I've had people who told me they couldn't eat bread, but when you treated the H. pylori, now they can eat it. So it doesn't mean the H. pylori caused the gluten intolerance. It just means that they had gastritis or even an ulcer that made them feel like so many types of food were causing problems.
Okay, but Dr. You realize that these people all, I don't know, I'm not a doctor, so I wouldn't know, but the people almost present with the same intolerances. So they'll have, they don't want to eat food that has wheat, then there's milk, then there's beans, and then there's spicy foods. So doesn't that present a picture of a similar kind of situation or disease? So when they don't eat all those things, they're okay.
No, that tells me that that is not simply a gluten intolerance, because there are many food groups in that list. So if they're intolerant to those things, to me, it tells me either there's some gastritis that just makes the stomach not be able to tolerate to several different types of things, or it could even be things like IBS and all that. Because, like, for instance, people who have true IBS, the symptoms are worsened by things like onions. So if they cook food with onions, that's a problem. And at the same time, gluten is still in that list, or even apples, you know? So with so many food groups and things like that, that makes me think that it's probably something else other than just simply gluten intolerance.
Someone else is asking, the H. pylori kit contains an amoxil that is presented in a tablet, yet the normal amoxil drug is usually as a capsule. Why the difference?
Usually that's just from the manufacturing side of things, because there are so many companies now making this. Some of them will have processes where they put it in a capsule, or others will have the tablet. I think as long as it's a reliable company, then that should be okay. One problem we have, of course, is the counterfeit products in the market. Unfortunately, this is common knowledge. Then, there's some products which find their way into the market, but, we're not sure. They've not been tested, So, there are many generic compounds or medications which are very good, but, it's always good to deal with reliable companies. So that you make sure you're getting the right thing. Sometimes maybe some of the treatments may not be working because probably the drug that you took was fake. Maybe there was nothing there. So of course these are regulatory issues, and government agencies are there to check this. And the more we're able to remove fake products from the market, the safer everybody will be.
Okay. I believe you answered the question on the source of H. pylori bacteria and prevention.
Yes. We talked about that. Really, it's a childhood infection. Most people get it when they're children. It remains quiet for years. Then later it might come and cause symptoms. And really, I think prevention, if we prevent our children from getting it today, maybe 30 years from now, they'll be okay.
But how do you prevent them from getting it? Because is it a hygiene issue?
It's this is a very funny. It's not like, obviously hygiene is good. We want to have hygiene in the children. At the same time, there is such a thing, believe it or not, as too much hygiene, where everything is sterile. And how do we know this? You'll find there are these conditions which are called autoimmune conditions. They are more common in these Western countries where everything is so clean. People are, even before COVID, people are sanitizing their hands and sanitizing everything. And the problem now with that is that you don't build the immunity. You don't build this good flora in the stomach. In fact, somebody used to say, if you need to build good balance of healthy bacteria, just go to a public toilet, because there are all kinds of things, And so, yes, we need hygiene, but at the same time, I think just be a bit normal. Don't be, now, yes, there's COVID, but after COVID, let's not sterilize everything and sanitize everything. I think just a little, let the children go and get dirty outside, like they show in those ads, let the children get dirty.
That is good.
Let them enjoy. Yeah.
Okay, I'll combine two questions. Does anxiety make GERD worse? And is there a surgery option for a persistent GERD?
Yes, I'll start with the second question. Surgery can be there. It can be done. That's the one I was telling you called a fundoplication, which can work if there is that hiatal hernia. And it can also be used even when there's no hiatal hernia as a reflux surgery. But again, that is not the first choice. It doesn't work 100% for everybody. So you don't want to just go for it as a first choice and then it doesn't work. Then you went through surgery and they're not even better. But it works for the majority of cases, especially if when very experienced surgeons are doing it. And so that can be had, but not as a first resort. That is something which should only be considered if, in certain circumstances where maybe somebody is totally allergic or intolerant to the medications, or things have stopped working as far as the treatment options and things like that. So yes, it exists, but not a first choice, more of a last resort. Then secondly, the other question.
Whether anxiety makes GERD worse.
Yes, now that's a very interesting question. I would say yes and no. Yes, in the sense that anxiety makes everything worse. When your mind is not happy, even your body cannot be happy. So if there's a reflux, it affects you more. And, there are known situations where, because the anxiety is a problem of nerves. Anxiety, that's what it is. The brain is full of nerves. But the second part of the body with the largest amount of nerves other than the brain is the GI tract. So we actually call it the second brain, or the enteric brain. So anything that affects this brain will affect this brain. And so that's what happens when somebody is anxious or depressed. One of the first places that manifests is in the digestive system. They might get constipated or have diarrhea. Same thing with reflux being in that area. In fact, the esophagus can be more sensitive in certain situations where the same amount of acid might cause more pain in somebody else than in another person because of the nerves in that esophagus. So there are treatments which actually can target those nerves. And there's one of the medications called amitriptyline, which sometimes you give to a patient, not because they have anxiety or depression, but because it can target the nerves in the esophagus and give somebody a better quality of life.
A relief. Okay. Is there an association between H. pylori and laryngopharyngeal? Hey, my God, you guys, when you type these things, you bear in mind where I come from. Laryngopharyngeal reflux.
Well,
is there an association between H. pylori and that one, reflux?
I think those are two different diseases. Those are two different diseases because H. pylori primarily affects the stomach and not the esophagus or the larynx. And so that's what happens. But when you have reflux going up there, that's a totally different issue. And there are actually some forms of GERD or reflux, which if the H. pylori is in the higher part of the stomach and you treat it, the reflux might actually get worse. So once in a while, you find a patient who they say, oh, since you treated me with H. pylori, my reflux is worse. Unfortunately, that's one of the things that can happen. But other than that, in general, there are two different conditions.
Okay. What can one do to rid themselves of blood in stool, which normally occur after a call? Is blood in stool a persistent condition or can it be cured once and for all?
Yeah, that's one of the things we said. Anytime there's blood in stool, that is always serious. You need to see a doctor because we need to see what is causing that blood. Sometimes cancer of the colon can present with blood in stool, or it might be an infection, or it might be hemorrhoids. So it's important to be very, very clear because if you're seeing blood in the stool, don't even wait. That one you need to see somebody quickly and to be sure that it's not something serious.
Okay. What are your recommendations on constipation triggered by diet?
Very good question. Diet needs to be healthy. If you're eating chapati and nyama only every day and potatoes, this can happen. You can get this type of problem, this constipation caused by diet. So what we recommend is that the diet should have high fiber. So always vegetables. In fact, we recommend vegetables with every meal. Okay, so vegetables with every meal, and apples. An apple a day keeps the doctor away. Eat your fruits. So diet can actually cause constipation. Walking, drinking water, all those things. Don't drink a huge amount of water, just a little bit when you're thirsty. We don't drink 8 glasses a day is no longer a recommendation. That is old history. So nobody recommends that anymore. So yeah, diet needs to be healthy.
Okay. If H. pylori is coincidentally found on biopsy but no symptoms, is there a need to treat?
Yeah, you see, once you find it, you have to treat it. Otherwise, don't look for it.
Okay.
Because if somebody was getting an endoscopy, there must have been a reason why they got that endoscopy and got the biopsy in the first place. So there must have been a reason. So in that case, yes, that needs to be treated. Because remember, we said that it is a leading cause of stomach cancer. So once you find it, so if you don't have to treat it, don't look for it. But if you find it, you can't leave it alone because, if you leave it alone and then 20 years later you get stomach cancer, you'll be wondering, why did I leave that? So if you find it, if you're getting endoscopy for some reason, it's important to treat it.
Okay. About what proportion of patients usually get treated for H. pylori and it goes away with these kits given that it's hard to treat H. pylori and it's very resistant to treatment? Like, what's the percentage of patients who are actually healed?
Yeah, unfortunately, with many of the common and many of the first-line kids, I would say it's probably in the range of 50%. It's almost 50-50. So, like I said, what we do to improve that number, to make sure that we're going up, and it's regional, because you see, like in Nairobi, there are studies which have been done that show about 20% clarithromycin resistance. There's some kids that contain flagyl, that's about 100% resistant, because in places like Nairobi, people are abusing these dawas a lot. You get a bit of upset stomach, you go get flagyl, you know. So next time when your H. pylori gets used to these drugs, by the time you discover you have H. pylori and you try to treat it, it's used to all these drugs. You find the patterns in Nairobi might be different from the patterns in Kisumu or Meru or wherever. They might be different. See? So there's a regional variation, even between countries.
Okay.
But unfortunately, from what we're seeing, I would estimate in the range of about 50% success rate. But sometimes we try to improve that by, nowadays, many gastroenterologists are starting with the second-line drugs. And also sometimes we add other things like Pepto-Bismol that I mentioned, which is a chewable tablet. That has been shown in studies to improve the success rate to the 80 and 90%. So if you get some of this combination, the success rate can be 90 to 95%. But those kits, and the other thing, like I mentioned, if you use the kit 5 years ago with clarithromycin, the first-line kit, and then now you go in and they find H. pylori again, and they use the same kit, even if it's a different manufacturer, but it contains the same clarithromycin. That one you can be sure it's not doing anything. You might as well be eating sweets. It's not doing anything. Yeah.
Okay. Now, someone has been having gas in their stomach late afternoons or after eating. They are 40 years. Is it an indication of something unusual? It's been like that for 3 months now.
Yeah, like I said, gas could come from a variety of reasons: infections, constipation, H. pylori, gastritis, even things like bacterial overgrowth, where there's imbalance between the good and the bad bacteria. Things like sometimes you do a stool test in such a patient, you might find there's amoeba or salmonella. So it could be a variety of reasons. And I think if it's causing discomfort, they should see their doctor so that it can be investigated what could be causing it.
Okay. What advice can you give if a child who is 6 years has been having gastritis pain and all tests have been done, even endoscopy, and still comes out negative, but the child still has gastric pain from time to time?
Yeah, I think for those, it's always good to just see the doctor and get the proper assessment done, because there are many reasons why they might have those symptoms. It might be probably time, to see the specialist, probably the pediatrician. They can advise them and guide them on, how to go forward. Do they need endoscopies? Do they need to see the pediatric gastroenterologist who sees children? So all those are different considerations. But yeah, I think it requires follow-up to ensure that the child gets better.
Okay. Can a random opening and closing of the sphincter be corrected through operation?
No. That the operation will not deal with that. The operation will only just tighten that looseness. So as far as the opening and closing, that's a function of the nerves in that area.
Okay. Are there health supplements that we can take to strengthen our system against this H. pylori infection?
Well, not really, because if it's there, it's there. It needs to be treated. And in general, we don't recommend supplements in general, because if you're trying to get vitamins from a pill, it's not going to work. It's probably better off if you eat a healthy diet, because eating the fruits and all that gives you not only vitamins, there could be other things that we don't even know. So we don't recommend supplements as in general. The only times when we recommend supplements are when we know that there's a problem. For instance, you've tested and you found there's a deficiency of maybe vitamin D, then you replace that. If you've done a test and there's maybe vitamin B12 deficiency, you replace it. So that's the approach that we use. or maybe women who are at risk for osteoporosis at a certain age, they might get calcium and vitamin D. But just taking in all these pills and all that doesn't do any good at all.
Okay. I'm combining two: use of apple cider vinegar to cure acidity, and also discuss the side effects to the intestines of drinking the diluted apple cider vinegar.
Well, it's quite acidic. That is the thing. So, if somebody is having a lot of acidity problems, it may not be, something that they should take in general. So that would be the comment on that. And it's one of those things people take and feel maybe it has health benefits and things like that. I wouldn't really say that there's a huge amount of health benefits that we're sure about with it.
With apple cider vinegar. Okay, how can you advise a person in their late 50s who has had ulcers throughout her lifetime, and when it's severe, she vomits frequently and lacks appetite to eat? Any medication you can recommend?
I think such a person needs to be seen. Needs to see a doctor. If they're vomiting, anytime somebody is vomiting, and that is something serious. That is not something that we can say that try this. No, just go to your doctor, get it sorted. If need be, see the specialists, physician, and all that to try and sort that out, because it's not normal to continue to have such severe symptoms and vomiting. That needs to be sorted out. It could be serious. Yeah.
Can the strong acid reducing medications like Nexium cause side effects like stomach infections?
There is a small association where people who've used high doses for several years of such medications, they've been increased slightly, very slightly. You're talking about, less than 1% increase in risk of getting certain infections, like an infection, one of the infections called C. diff, things like that, or even reduced bone density and things like that. But these are rare, only at high dose, and for a long time.
Okay. My mom had bleeding ulcers and could get triggered when in shock or too worried. She has not gone to hospital for the same, but it just stopped. Can it recur, or is it totally curable?
It can be curable depending on what caused it. For example, if it was caused by H. pylori, like we said, that's one of the major reasons why people get that, then the H. pylori has to be fully and truly cured. Because if it's not, then this can come back. Or for instance, if it was caused by aspirin and these other medications, ibuprofen, brufen, and all that, if they take it again, it can come back. So if the underlying cause has been handled properly and eradicated completely, then usually people are cured and cured completely.
Okay. What causes heartburn after eating, and can it be reduced or controlled?
Heartburn usually is from reflux. When people talk about heartburn or burning behind the chest, that's usually reflux. And it can be treated like we talked about reflux with those medications, and also the non-medical lifestyle things you can do and diet.
Is taking yogurt or maziwa mala bad if somebody has acidity issues?
No, not at all. That's good stuff. Mala ni bora.
Okay. Is it normal to have bowel movements after several days? What's the normal frequency of bowel movements? These are people who go for long haul, maybe after 2-3 days.
It should be every 1 to 2 days. If somebody's going 3, 4, 5 days, that's not healthy. There's probably constipation going on, and it can cause issues like hemorrhoids and all that.
The other way around also, if somebody maybe goes 3-4 times a day, is that also normal?
That's also a lot, especially if it's loose. It could indicate, something that's not right with, especially with the flora, or the good bacteria may be too low, those sort of things.
Okay. Does taking pilipili have any adverse effects on the GIT, especially natural pepper? And also, does alcohol, especially hard liquor, cause gastritis? gastric issues?
Well, these are things that can cause irritation if there's
Yeah.
an underlying gastritis. So
Mhm.
somebody might feel fine because you might have that gastritis. Remember the picture that I showed you. You might
Yes.
feel fine, but now it's like now adding fuel to the fire.
Mm.
Okay. So
Yeah.
if you have that gastritis,
Mhm.
you can see that, then you go ahead and it's like this, and you might feel fine. You might not feel any issues.
Mhm.
But then you drink vodka, itachoma hapa
Mm.
sana. Huh? Then you might be vomiting the next day. Same thing with pilipili.
Mm.
So if your stomach is healthy like this one, those things shouldn't cause too much problems.
Yeah.
So that's exactly what happens. It's more of, is there some underlying issue? And then those things trigger it and make you feel bad.
Okay. Does overeating cause GRD or reflux?
Yeah, it can, especially too close to bedtime.
Uh-huh. Okay.
Yeah, some people notice that when you eat a lot, that's when now inasumbua sana, so they try now to avoid eating so much.
Mm.
But yeah, it's just a question of the stomach is too full. Ni
Mm.
kama tu mtungi ikiwa
Ikijaa
sasa
inaanza
imejaza
kumwagika.
mwagika huko. Yeah,
Okay.
you bend
Now,
forward like this.
it's true. Are there home remedies for constipation and recurrent dyspepsia?
Well, the main thing for constipation, we talked about fiber. Kwanza sukuma wiki. Sukuma wiki, if you eat a lot, you can even get diarrhea.
Sukuma wiki or the traditional vegetables?
Both of them, if you eat like the whole thing, some people get diarrhea. So it's actually a good remedy, which means if you're eating it regularly and you have constipation, it can actually make your stool normal. So this is very good stuff. All those traditional sukuma wiki, all those things are very good.
And the dyspepsia?
The dyspepsia simply is just that stomach discomfort and all that. Some people drink milk, and there's so many other things out there. Home antacids, some traditional soups can do that. Yeah. So yeah, they're there.
Okay. Is it advisable to take maziwa mala for a pregnant woman?
Yeah, nothing wrong with that. Should be fine.
Okay. Okay. Is it healthy to add, this must be add, they put ask, but is it healthy to add salt in food after cooking?
Salt, basically, with all things is moderation. You don't want to overdo it. Yeah. So if you put enough during cooking, then you don't have to add. But again, you don't want to do too much even during the cooking.
Okay.
So yeah, not too much of that.
Does milk relieve GERD?
Well, it can make you feel better because it can act as an antacid to kind of neutralize the acidity. So it can.
Okay. But it makes you feel better completely or for a short period?
Probably for a short period in most cases. If there's significant GERD, maybe just for a short period. But a lot of people notice when they drink milk, they feel better.
Okay. Does diastasis recti after giving birth increase my chances of getting GI problems?
I'm not sure what that is. What's that?
Diastasis recti, I don't know.
I don't know what that is.
Maybe we pack it. We'll probably answer it next.
All right.
Next week. Okay. What's the impact of salt to GERD?
Probably not too much. Probably it wasn't in the list. The ones with the biggest impact are the ones I listed, peppermint, alcohol, chocolate, all those nice things.
Even chocolate?
Even chocolate seems very.
Ouch. Why is there a surge in H. pylori infections?
I wouldn't say there's a surge. I just say it's more recognized now.
It's now
just
we
being
are
tested.
aware.
Yeah, people are more aware. It's being tested everywhere.
Okay. What would be your advice to someone who suffers from celiac disease?
Celiac disease, like I said, it's something that, it's really the true gluten intolerance. So this requires very good and close follow-up with the doctor to make sure that the diet is followed, and first of all, to make sure that it's a real celiac diagnosis, because the diagnosis has to be clear. It's not just that you don't like celiac or bread or wheat makes you sick. It has to be diagnosed specifically through biopsies of the small intestine that have to be clearly proven that that's what it is. And then also there's some blood tests specific for celiac which require to be positive before you can make that diagnosis.
Okay, we are down to 3 last questions. When the case has become gastric, how do you manage with the diet to heal? And does it heal completely? After how long?
When what? Sorry, I didn't get that.
When the case has become gastric, how do you manage with the diet to heal? And does it heal completely? I think maybe they're asking if you have gastritis, how do you manage with that? Yeah, how do you manage with the diet to heal? And does it heal completely? After how long?
Yeah, gastritis, like we said, you can see it in the picture. Really, we need to find out what's causing it. So diet alone may not be adequate to heal it. As much as, healthy diet is always good, but if it's caused by H. pylori, that H. pylori has to be treated. If it's caused by aspirin or brufen, then that has to be stopped. It's as simple as that. If it's smoking and alcohol contributing, then those have to be stopped. So diet doesn't have a massive role in this condition. But, obviously, like we said, if there's gastritis or gastric ulcer, then all these pili and things like that can make you feel uncomfortable. But that's because there's already a problem. So that problem needs to be sorted out.
Okay. Now, I know you had answered this, but just repeat it for the sake of the listener. If H. pylori is contracted in childhood, how can we reduce its chances? And why is it that I think the one for reducing its chances is just exposing our children to good bacteria? And why is it that in Africa, the rate is higher than America?
Yeah, so we think it's because of just the socioeconomic lifestyle and development. There are those conditions which are more common in countries like Africa and Asia, where, yes, now there's a more modern lifestyle, but probably 50 years ago, everything was very traditional. And whereas maybe for the Western countries, maybe they moved from traditional to modern a little earlier. That's why there's less of it. So that is part of it, and it's thought to be maybe socioeconomic status. So you'll find that maybe as people get more developed and more people have access to running water and things like that than happened in the past, then the numbers can gradually go down. So that's where you'll find it in countries like South America, Asia, and Africa. Those are all countries where this development is more recent, as opposed to maybe Europe and America, where maybe they had running water probably more years than we did.
Okay. And for the last question of the night, on the apple cider vinegar issue, you had already made a comment, but the listener says they didn't get it clearly. They want you to repeat on that. Is it good or bad? And is H. pylori genetic?
Okay, H. pylori is not genetic. Apple cider vinegar, I wouldn't really go as much as saying whether it's good or bad. I'll just say it is acidic. So if there's, let's say, an ulcer, gastritis, or reflux, it could make the reflux symptoms worse. So that would be my comment about it. Otherwise, it's if there's nothing like that, it's a good drink. I don't really know of any other medicinal effects or anything like that it has. I know people like drinking it, feeling like it's healthy. I'm not aware of any of those medicinal effects.
Okay. So there's somebody who had asked on the chat area where you are located in case they want to come and see you.
Well, our clinic is called Gastro and Liver Center. We're in Parklands in Doctors Park building.
Okay. So that is it. We've answered all questions except on the there's something, diastasis recti. I think Dr. will do a little homework, then come and answer us
Maybe
next
we
time.
can see the spelling. Maybe it's about how it's spelled.
Oh, it could be my pronunciation.
Issue,
oh my God. Okay.
Maybe it's a total different condition,
oh my
in
Lord.
obstetrics. I'm not sure, but we can definitely look at that and see.
Yeah, I think I'll send you this. It could be my pronunciation, primary.
Or the spelling. Yeah.
Okay.
I can look at it.
Yeah. So thank you so much, ladies and gentlemen who have joined us tonight. We hope we have answered your questions comprehensively. We look forward to having you next time. I know next time Dr. is going to expand more on GIT issues, especially touching on GIT cancers. So we look forward to hosting you again next week. Prepare your questions. If there's any question that you think was not answered comprehensively this time round, please let us know so that we prepare enough for it next time. But from me to you, thank you so much and good night.
Good night.
And Dr. maybe one last word from you, or you've said good
Thank you.
night.
It's been a pleasure. Thank you for hosting all of this. It's very different than from a live meeting, because live meeting you can get feedback immediately. So here I'm just having faith that there are actually people listening. So
I can assure you there are people listening. So thank you so much. Okay, guys, good night. Enjoy your evening.